Hello and welcome to Clinical Update, a podcast aiming to update you with key learning points for clinical practice. My name's Pat Anderson. I have my colleagues with me today.
I'm Rhiannon Ashman.
And I'm Sangeeta Krishnan.
So apparently, fire and forget is no longer an option for GPs when it comes to lipid management. That's the opinion of our interviewee today, and he's Dr Pipin Singh, and he'll be talking to me later about how guidance has changed and where the newer lipid-lowering agents fit into the picture. Dr Singh is a practicing GP and GP trainer, so he's really well placed to give you practical insights. And after our interview, we'll bring you 3 key points from a module on osteoporosis, focusing on guidance from the National Osteoporosis Guidelines Group, which I'll refer to as NUG. This guidance has changed, so it's important to know about. And just as a reminder, this podcast does count as free CPD, and you can go to the MIMS Learning website to claim your CPD certificate. But now, over to Rhiannon and Sangeeta for a discussion about an interesting case.
Thank you, Pat. Well, I hope that you're not listening to this podcast on your lunch break, because we are talking about vomit, specifically vomit phobia, also called emetophobia. Now, this is an interesting one because the prevalence rates for emetophobia in the literature are really quite low, around 0.2%. So we weren't sure if this was going to be a particular learning need for our learners, but we heard from one of our authors and from our mental health clinical advisor that this condition can actually be misdiagnosed, for example, as OCD, and it's probably under-recognised. And in fact, community samples do seem to suggest much higher prevalence rates, just under 2% in men, and it's significantly more common in women at around 7%. The author of this module, clinical psychologist Dr. Alexandra Keys, actually says that anecdotally, emetophobia is the most common phobia presenting to clinical services.
Interesting how studies say that the prevalence is so low, but in actuality, a much larger percentage of the population have emetophobia. I think this is something all clinicians should know about so that they're better prepared when they encounter this in practice. So is emetophobia a phobia of vomit in general, or just a fear of being sick themselves?
So in around half of people with emetophobia, they have a fear of actually vomiting, but a proportion also fear others vomiting. Usually this is related to a fear of catching a bug from the person that's vomiting, which would make they themselves sick, or a fear that seeing someone else be sick will trigger the urge to vomit themselves as well. We all know the sensation, although we might not experience the same fear that people with emetophobia feel.
And how would this impact people's lives?
Well, as with any phobia, this can be really debilitating. People often try to reduce their exposure to situations where they might see vomiting or feel nauseous themselves. Interestingly, there's a lot of overlap as well with the symptoms of other conditions like OCD or eating disorders. So people might wash their hands excessively or avoid certain types of food like seafood to minimise their chances of getting sick. In fact, this case that we're going to talk through in a minute, we'll see the lengths that the patient went to avoid vomiting.
So I understand this case is about a woman with 2 young kids.
Yeah, Sandra was 39. She had 2 young children. She presented to her GP with anxiety about her children catching a stomach bug and giving it to her. She said that her worst fear was that she would vomit repeatedly for days and not know when it would end. And we all know that catching a stomach bug from your children is par for the course for those with young kids, so we can imagine how significantly this phobia was impacting her life.
Yeah, this would have had a significant impact on her day-to-day life. What sort of things had she been doing to manage her phobia?
So to try to manage the anxiety, Sandra said that she would clean the house excessively. She avoided certain foods and she was hypervigilant to any local outbreaks of viruses. She constantly asked her children whether they were feeling okay, and if they were ill, she isolated herself from them, leaving them with her partner or her mother-in-law. And it was starting to have an impact on her kids as well, because she said that she wouldn't let them socialise with other children, or she would keep them off school when there were local outbreaks of illness.
And what was the first thing that her GP did to address this?
Well, the really key thing that her GP did here was that they didn't dismiss her symptoms. And it's important to remember that people often have a long history of emetophobia before they seek help. So offhand comments like "nobody likes vomiting" can have a really negative impact. But in terms of treatment, initially she was referred for CBT at her local NHS talking therapy service. And this module says that CBT has a good evidence base for reducing symptoms, and it's the first line treatment for emetophobia. It's usually offered over 12 to 20 sessions, depending on the severity.
So, in addition to the CBT, which I'm sure would have helped, I'm wondering if there's any evidence for using pharmacological treatment?
Well, the short answer is that no, there is no medication licensed for treating emetophobia. The longer answer is that there is some rationale for prescribing SSRIs in people with severe symptoms that overlap with OCD, and this would typically be given if they've already completed a course of CBT and not responded to it, or not responded fully to it. The catch-22 here is that nausea is a common side effect of SSRIs.
Oh no, that sounds really awful.
Which is often difficult for people with emetophobia, obviously. So you might need to reassure them that this feeling is just a short-term side effect and it doesn't indicate that they are actually going to vomit. The module also lists a few other hints and tips for if you're prescribing a medication with this side effect in people with emetophobia. And in Sandra's case, she actually requested a prescription for anti-nausea medication, which the author says is quite common in patients with emetophobia. But any nausea that Sandra felt was likely to be a result of her anxiety, so prescribing this wasn't recommended.
So, was Sandra eventually able to overcome her phobia after she had the CBT?
Yes, Sandra completed 12 sessions of CBT and she reported improvement in functioning and quality of life. But then she had a setback about a year later when there was an outbreak of norovirus at her children's school and her symptoms got worse again.
And what happened next?
So after this, her GP prescribed her sertraline and she completed a second course of CBT, which improved her symptoms again.
That's good. So it was really worth referring her for the treatment for herself and for her children.
Yeah, definitely, I agree. Thank you for discussing this with me, Sangeeta. I've certainly found it really interesting. And there's more detail in the module itself about other potential presentations and treatments to avoid. The link is in the podcast notes if you'd like to read more.
Thanks very much, Rhiannon and Sangeeta. Really interesting. So we go now to our interview with Dr Pipin Singh about lipid management. I'm delighted to have with me today Dr Pipin Singh. A very warm welcome to you.
Hi, good afternoon, Pat.
So Dr Singh is a GP and GP trainer in Tyne and Wear, also a training programme director, and he's a very regular writer, chair and presenter for MIMS Learning for our e-learning modules, our virtual events and our live in-person events. For example, he chaired our virtual event MIMS Learning Live Digital in March, and he'll be back in June at our MIMS Learning Live London event on 7th of June, chairing a stream that has respiratory in the morning and mixed topics in the afternoon. And he'll also be speaking in London on the very topic that we're discussing today, which is lipid management. So, Pip, what are your impressions of the London event?
I think it's always a fantastic event in terms of what's laid on topics-wise. It's always great to network with people, meet new GPs from up and down the country, not only GPs, other allied healthcare professionals. It's full of fantastic CPD topics, and often it's delivered by colleagues who give us some practical messages that we can take away to our practices and put into practice pretty much, hopefully, or I'd like to think the next day anyway. And that's one of the best things about it, because often you go to these things and you get some advice and it's often not maybe relevant to primary care or whatever, whereas this is very relevant to the work that we do on a daily basis.
Brilliant. Obviously, you're going to be speaking about lipids. Can I ask, have you got a particular interest in this area, or is it just something that, as a GP, that you just need to be on top of?
It's something that we've been doing at my surgery for the last year and a half, and one of my pharmacist colleagues has recently taken a lead role in this in terms of starting inclisiran in-house. So as a result, we've been doing a lot of lipid work, and we've also linked up with our hospital colleagues and been more proactive at case finding in terms of patients who may be eligible for more of the newer agents such as inclisiran or some of the PCSK9 inhibitors, which I'll talk about during the podcast. I also have an interest in diabetes, and obviously there's a lot of overlap there with cardiovascular health, and in and amongst that is lipids as well. So,
why are lipids such an important part of cardiovascular disease prevention?
Well, we know, Pat, that high cholesterol is one of the most significant risk factors for cardiovascular disease. Globally, around a third of ischemic heart disease is attributable to high cholesterol. It's estimated to account for about 7% of deaths and 3.7% of disability adjusted life years in England. Cardiovascular disease burden is a major burden of ill health in the UK and second to malignancies. And it does cost the NHS a significant amount of money, around £7.4 billion a year has been quoted recently. So we know that raised LDL is one of the top 3 modifiable contributors. And if we can reduce that by even just 1 millimole per litre, it's tied to a 22% reduction in major vascular events, whether that be an MI or whether that be a major stroke. And where I work in the Northeast, there's the lipids account for, or cardiovascular disease counts for 24% of all deaths. So it's very important, not only in the country, but definitely where I work, that we try and get this down, improve it, and help people live better, longer quality lives, really.
Yeah, I mean, 24% is an astonishing figure. How does that compare to other parts of the UK?
I couldn't give you exact figures for other parts of the country in terms of specific numbers, but I do know it's a lot higher than a lot of our other sort of more, where you are in the southeast. I think the northwest is quite high as well, and I think that there is a bit of a north-south divide where the north is slightly higher than the south. That's we see for a lot of other things as well. But in terms of actual specifics, I couldn't tell you how the northeast compares to the northwest or the southeast, but I definitely know the north is higher than the south still.
Yeah, no, that's really interesting, and I understand the thing that you would start with, lifestyle measures, rather than going to drug therapy straight away for somebody with hyperlipidemia. So to what extent do you think lifestyle measures come into the picture?
Well, I think prevention always remains better than cure, doesn't it? So lifestyle, as you say, you would tend to go to that first. And in my opinion, that remains critical. And it's important that we still focus on those modifiable risk factors. So smoking, alcohol, weight reduction. And we know that there are a lot more smoking cessation clinics locally available to us. Although they were sort of diminishing, they have seemed to have come back up a bit more. So we can always refer people to our smoking cessation services that are local to us, or whether we may have one in-house. Making sure your care navigators are aware of smoking cessation services locally so that they can signpost patients to these services. We're all probably signed up to the weight management service, where there's different tierings, tier 2, tier 3, tier 4 weight management services. So being aware of your local weight management service is important. Addressing obesity, patients who may have that as a condition, whether it be directly related to why they're coming in or not related, it's still always important for us to try and address that and refer on if needed. And obviously other things like alcohol, which we know have an impact on weight, and which in turn will also have an impact on lipids as well. So it's important that we always go back to basics and address all of these things. And if that requires some drug therapy on top of that, then great. But at the same time, never forget that lifestyle is absolutely critical to bringing these things down, such as lipids, and obviously all the other things that it can impact, like diabetes and so forth.
We're taking a bit of a focus on healthcare inequalities this year at MIMS Learning, and obviously social deprivation must come into the picture here. It must be that much more difficult to eat healthily, to give up smoking, give up alcohol, if you've got a stressful, chaotic life with multiple health and social problems. So do you think is it more difficult to pursue lifestyle measures for certain people?
I mean, I think, yes, there's no doubt that there is some inequalities there, but we do know that there are options remain available to all patients, and we do now know that processed and fast foods are actually more expensive than fruits and vegetables, say, for example. So it's important for people to bear that in mind, because I think it is that whole, well, fruits and vegetables are expensive and healthy food is expensive. Whereas, yes, in certain things might well be, but that isn't always the case. And, if short term, people might think, well, I'll get some fast food or I'll get a microwave meal or whatever it might be. But actually, if you top that up over a month, you probably save a lot of money by more healthy eating than buying sort of more faster foods or more processed foods. But there are no doubts that inequalities in this country mean that some people won't be able to access certain healthy foods that, say, more affluent areas may be able to access, for example. But that shouldn't stop people thinking, oh, well, I can't do that, or I can't do this, or make, it doesn't take much to maybe make some nice healthy soup, for example, or using very basic veg, which costs very little.
Okay, well, that's quite hopeful. Thank you. What as a GP, what are you aiming for? I know that NICE, you've recently updated a module for us about NICE guidance on cardiovascular risk assessment, and NICE has revised its lipid targets. And can you kind of give us a quick rundown of what you feel you're aiming for as a GP?
Yeah, absolutely. So obviously the PCN-DES of 22 and 23 aim to reduce the impact of what we call the ABC of cardiovascular health. So that's AF, hypertension, and cholesterol. So we now know that there are many more lipid-lowering drugs available to us, and there's been a rapid evolution in these over the last sort of couple of years. Hence why, I've done an article for you to try and help people understand what the sort of changes have been, and obviously why we're doing this podcast today to hopefully people give people that summary of things that they may be able to do in practice. So basically the targets for what NICE introduced they've just actually updated them as well in December 23, NG238. There were some changes to secondary prevention. The aim is to keep in secondary prevention, to keep LDL cholesterol levels at 2 or less, or non-HDL cholesterol levels at 2.6 or less. Although I think a lot of local targets still are 2.5. NICE did slightly modify this in December 23 to 2.6, but I suspect a lot of practices will still be sticking to non-HDL of less than 2.5. And I'm speaking specifically here about secondary prevention. And the reason they relaxed this slightly to 2.6 is that they felt that the QOF targets weren't being met and that cardiovascular deaths were still quite high. And they felt that relaxing that target by 0.1 of a millimole, they weren't compromising safety too much there. The other things they've done there, Pat, is a big push for ezetimibe, so additional therapy on top of the statins that people might be already taking, if there's no contraindications to them, and if they're still not meeting the targets on the statin, it's to go very much or add in an extra therapy in the form of ezetimibe or something like bempedoic acid, or considering some of the newer PCSK9 inhibitors or something like inclisiran.
So it sounds like there's quite a range of options then that you can now go for, including statins, but also going beyond statins.
Yes, absolutely. So statins remain the forefront of lipid-lowering therapy, forefront of treatment, and that's what most practices will commonly do. I think ezetimibe has been around for a while. I couldn't tell you exactly how long it's been around for, but I think a lot of people will be aware of it. But I think what we're going to see now over the next couple of years, a lot more people getting ezetimibe added on to their statin therapy, whether that be for primary prevention or secondary prevention, in order to get that non-HDL cholesterol down.
But do statins remain the mainstay? They're not going to be replaced by anything else?
They're not going to be replaced, no, not at this present time. And I think they'll definitely remain mainstay treatment for the foreseeable future, I suspect. But yes, I think the biggest changes they're going to see, as I say, are add-ons to the statin drugs that we're already using.
Okay. And obviously there's an issue there about statins and people being concerned about side effects or saying that they experience side effects such as muscle problems. So how do you address that in your practice?
Yeah, so I think there's lots of fear around statins still with some patients, and I think it's just explaining to patients or making them understand why it is that they're taking them, making them understand the risks of not taking them, and also using sort of patient decision aids around the whole pros of taking them, the downsides of taking them, and the patient decision aids are often quite helpful because they often have pictures which makes it slightly easier to convey the message around what happens or how many people might have a heart attack or a stroke if they're not taking the statin, say, for example, versus the benefits that they may get from the statin. So it explains the numbers in slightly more simplistic terms. And it's also just about explaining to patients that side effects often are not that common. And if they take the medication is stopped, that the side effects will often disappear. Because I think a lot of the fear that people get are they've had a neighbour that's taken one, they had an awful side effect, they've read something in the press, and obviously people have a lot more access to information than they've ever had. So there's a lot of scaremongering out there now. So it's important to try and address some of those fears. And a lot of those fears are actually also not true, and just kind of explaining that to patients, really.
Yes, it's one of those areas where people have heard quite a lot about it, probably. And so I guess as a GP, if you have a discussion with them about correcting some of those ideas, if they've got the wrong impression, then that could be useful.
Absolutely, and that's our bread and butter as general practitioners. We're often addressing people's fears, and either yes, some of them might be true, and then obviously we've got to sort of go through that with patients. But a lot of the time, these fears are not true, and also just explaining that there are alternatives now, as we've just talked about. So if they don't want a statin, we've got a range of different lipid-lowering therapies now that they might be eligible for. And just making people aware of that. And the key thing is making them understand why, again, it is that they're taking them. And that's absolutely critical, isn't it? If you take your statin, you're doing it for a reason. It's to prevent that stroke or that heart attack. And a lot of people also think, they'll have a heart attack and, a lot of patients say, have a heart attack and kills me, then so be it, or have a stroke and, it kills me. But actually that isn't often the case. They'll have a heart attack and they'll survive it, and they'll be left with a significant disability post their heart attack. And same with potentially their stroke. The stroke won't often kill them. It'll leave them with a significant disability that themselves and their families have to live with. So, and it's important to try and convey that sensitively as well to patients.
Yes, that must be a tricky conversation to have.
It can be, yes, absolutely. And you obviously might need to pick and choose the right patient that you have that discussion with, and it might not be that you have to have that sort of discussion with everybody, but it might be for some who are really struggling to get that message home, explaining it and maybe taking that explanation a little bit further, for example.
Interesting. And can I ask at this point, what it may be good to bring in the role of the clinical pharmacist? I mean, when it comes to this discussion about medication and why you're taking it and whether you're adhering to it and how you're getting on with it, is that a role that the pharmacist can play?
Yeah, absolutely. And I think most practices will have a pharmacist attached to their surgeries now, and it is a huge piece of work. And obviously as GPs we're doing more and more every day, or as surgeries we're doing more and more every day. And I think this is a piece of work that one of your clinical pharmacists can do, because they probably do have a little bit more time to be able to spend with patients and go through the pros and the cons of different treatment options, which, yes, we can do. But there's also a number of other things that as GPs we have to do in terms of managing acute care and so forth. And we do know that there are other colleagues within our teams that can manage chronic disease slightly possibly better than we can, because they have the slightly longer appointments than we do. So I think using your pharmacist to be able to have those conversations, and someone who's upskilling and having that conversation day in, day out, and it's becoming more and more competent at having that conversation, and as a result will be able to possibly convey the message slightly better perhaps, is something that I think all practices should be thinking about if they're not already doing that.
Great. And do you think that adherence to statins is an issue? I mean, do you find that people aren't taking them, or is that not really much of a problem?
I mean, I think again, it probably comes back to in terms of the barriers of why people might not be taking them, is getting patients to understand why they're taking them again. Other barriers include obviously if patients have a lot of medication, polypharmacy, addressing polypharmacy, making sure patients do understand why they're taking their medications. There's the medications that can be stopped as well. They might be taking things that have been taken for a long time, but actually they haven't been reviewed. And if you can maybe try and understand why they might need some lipid lowering therapy actually, but they don't need something else, that might help. Again, just going over those side effects that they may have experienced in the past, those fears around those medications, and addressing sort of negative press coverage that they may have come across is absolutely important. But side effects are not uncommon with statins. So I think it is important that if anyone is experiencing side effects, that's obviously addressed, and alternatives are looked at with regards to whether that be a statin or an alternative lipid lowering therapy.
Great. And with the the other therapies that you've talked about, in addition to statins or sometimes as an alternative, are GPs kind of up to speed on those, or is there a bit of learning needed around how to deploy those?
It's important for us as clinicians because it's been such a rapidly evolving area recently, and I have no doubts that a lot of my colleagues will be struggling to keep up to speed with this, and some will be better at it than others, and there's no doubt about that's just general practice. So I think it's about thinking about things in terms of what's primary prevention and secondary prevention. So in terms of primary prevention, what are we aiming for? It's about Q risk assessment. Are they between 10 to 20%? Then we should be thinking about lipid lowering therapy. If they're above 20%, then we need to be definitely offering patients lipid lowering therapy. Going back to the modifiable risk factors as always, as we discussed earlier on. And then if they are meeting the threshold for lipid lowering therapy in primary prevention, then we should be thinking about atorvastatin 20 milligrams. And then it used to be fire and forget. And I think the biggest change as well, because a lot of people will still have in their head, oh, it's just fire and forget, whereas actually it's no longer fire and forget. It's actually blood test at 3 months. What's that non-HDL cholesterol doing? Has it come down to less than 40%? Has it come down by more than 40% at base compared to the baseline? If it hasn't come down to if it hasn't come down by more than 40%, do we need to be increasing the dose if patients are able to tolerate that higher dose? If not, do we need to think about augmenting with something like ezetimibe if we're able to use that? And if we're not able to use that, then do we need to be thinking about something like bempedoic acid? Now, if we're in secondary prevention, again, it's thinking about whether the patients need to be on a higher dose of a statin. Are they tolerating that dose? And if they're not tolerating that dose, a reduced dose, but keeping a very close eye again on that non-HDL cholesterol. Is it less than 2.5? And we should be aiming for less than 2.5, even though, as I said earlier, NICE said less than 2.6. You do have maybe a little bit of wriggle room, but I think a lot of people, as per the PCN DES, will be sticking to a non-HDL of less than 2.5. Other agents that come into play here. Now, I suspect a lot of practices won't be starting the newer agents in-house. So that's where your lipid lowering clinics will come into play, and sort of liaising with your local lipid specialist. But this is where the LDL is more important. So if you have an LDL of 2.6 to 3.4, then you'll be eligible for one of the newer agents called inclisiran. And if you have an LDL of 4.1 or more, then you should consider referring to a lipid clinic for one of the new PCSK9 inhibitors. And these are the sort of newer MAB drugs that we're using for lipid lowering. And you tend to find with PCSK9 inhibitors, you should get a 70% reduction in LDL. Patients have to self-inject every 2 weeks, and this is a hospital monitored drug. With inclisiran, you'd probably get around a 50% reduction in LDL, and it's a 6-monthly injection. And it can be monitored in primary care, although I know this will vary from area to area as to who's willing to start it inclisiran in primary care, whether it needs to be hospital only, depending on local formularies as per practice. So I hope that was a reasonably clear summary. So there's a lot of information there.
Sounds like a brilliant potted guide to the whole thing to me. And so it sounds like it's a bit of a changed picture for GPs, and they need to be a bit more kind of on the issue.
Yeah, and I think going back to the fire and forget thing in terms of it's not fire and forget anymore, because historically it was very much on atorvastatin, end of story. You really never did anything with that again. As I've just explained there, that is very, very different now in terms of how that looks and how we monitor and what we should be doing with cholesterol results at annual reviews.
So that sounds like it's a more hopeful prospect for patients because then more can be done, and hopefully more can be done to actually bring your risk factors down.
That's it, and more can be done. And it goes back to what I was saying earlier about cardiovascular disease being a major burden of ill health in the UK, and just a simple reduction of 1 millimole being tied to a 22% reduction in major vascular events. And that's the key thing there, and that's the reason there's more. That's the reason we're doing more, because of those startling statistics that we know about cardiovascular disease.
So just a couple of last questions, Pip. First of all, frail elderly, if you've got a very elderly person in your consulting room, how would you address the issue with them?
Yeah, it's a tricky one, Pat, because I think this does get asked a lot, and I think it's often at the discretion of the clinician and after discussion with the patient, really. And a lot of it comes down to comorbidities and degree of frailty. Because we have some patients who we know patients are living longer, and we know we have lots of patients in their 90s who will potter into the surgery and look absolutely fine. And then we have a lot of patients also in the same age group who will have significant comorbidities and potentially be in a care home. So it's very variable what someone in their 80s and 90s will have, and whether they'll be mild frailty to severe frailty. So it may well that you need to increase their doses of medications and intensify those treatments and aim for the same targets of non-HDL that you're aiming for in younger people. But it might be that if they're in a care home and they're bedbound, that it's totally not acceptable to do that, and actually giving them medication can potentially cause more harm, because some of the patients we know in care homes may have dementia, not be able to communicate with us. We do know statins have side effects, and actually the benefit that they will be conveying from taking that statin is small, if not to zero. And we know a lot of the trials in these treatments have not been done in elderly patients, so that's something else to bear in mind. And when it comes to primary prevention, for example, and we're using Q-risk, we also know that Q-risk, we can't use that in the over 85. So these are all things just to kind of bear in mind when thinking about lipid-lowering therapies. I don't think I would blanketly say over a certain age you shouldn't be having it, because that's not correct either. So I suppose what I'm trying to say is take it on an individual basis. And if necessary, it might be that you have to have a discussion with the patient's next of kin if the patient's unable to or hasn't got capacity or unable to communicate with you for whatever reason.
Thank you. And finally, any sort of thoughts on other key learning points for GPs?
Yeah, absolutely. So I think going back to what I was saying earlier, it's no longer fire and forget. Be more alert to your annual cholesterol results. Use your practice pharmacist to help, for sure. Be aware of newer drug groups. I'm not saying you need to be, you won't probably be using them in-house, but just be aware that they exist and that you may need to refer on for these newer drug groups. So the PCSK9s that I was talking about. Be aware of inclisiran, because that as a newer drug you may well see on patients' letters, and you need to be adding to your patients' records. I'd say be alert to the drug reactions with newer drugs. So I think these are new, so we are still learning more and more about them. So if you think a patient may have developed side effects to the newer agents, don't forget to yellow card them. And one thing I haven't mentioned so far is the recognition of familial hypercholesterolemia, and NHS England are on a big drive to recognise FH. So if you are seeing patients with total cholesterols of greater than 7.5, just have in your mind, could this be familial hypercholesterolemia, and apply your sort of Simon-Broom criteria that we know exist for diagnosing FH. And also just other sort of practical tips. Can you put targets on the pharmacy or patient text on your clinical system about what level of non-HDL you might be looking for? And I know that's something we've been doing in practice. And could it be a QIA or a QIP you could give to one of your medical students, GP registrars or F2s to do?
Brilliant. Some great practical actions to take there. Well, thank you so much for joining us, Pip. Really useful to go through with such a clear summary of what GPs should be thinking about. And if you're listening to this podcast, you're interested, please do have a look at the cardiovascular risk assessment module that Pipin has updated. There is a familial hypercholesterolemia module as well. And we've got MIMS Learning Live London coming up on 7th of June. So please do join us then for more discussion of lipids. So thank you, Pip.
Thank you, Pat.
So we're back for 3 key points on osteoporosis, based on a module that was originally written by Dr. Jessica Garner and was updated recently by Dr. Anish Kotecha to take account of changes to guidance from the National Osteoporosis Guidelines Group, or NOG. So these changes did happen a couple of years ago, but it's still worth recapping, I think, because not all GPs may be aware of the changes, given that they have to focus on so many different clinical areas in their practice. So what's our first point?
So the first key change in the guidance is that people who have a clinical risk factor for fragility fracture should be given a FRAX assessment. That's any postmenopausal woman or any man aged over 50 years with a clinical risk factor, as age contributes to risk independent of bone mineral density. There is quite a long list of clinical risk factors in the guidance, and these include the obvious ones like history of prior fracture and low body mass index. But also in the list, there is parental history of hip fracture, smoking, oral glucocorticoid therapy, alcohol intake of 3 or more units daily, conditions such as rheumatoid arthritis, and diabetes. So that list is something for GPs to bear in mind. In the module, Dr. Kotecha provides some pointers on action to take based on the FRAX results, including for patients for whom bone mineral density measurement is not practical.
The second key point is again on assessment. One of the key recommendations that has changed is around back pain. So Dr. Kotecha points out that you should now consider imaging to look for a vertebral fracture in people with acute onset back pain who have risk factors for osteoporosis. On the NOG website, there's an expansion of this to include consideration of imaging in people with back pain and more than 4 centimetres height loss, kyphosis, recent or current long-term oral glucocorticoid therapy, or a bone mass density T-score of less than or equal to 2.5. Again, that sounds like it would be an expansion of when you would consider imaging. That is widening the approach to include more patients.
Thanks, Rhiannon. And our third point is about treatment. Dr. Kotecha mentions a drug called denosumab, which is a monoclonal antibody approved for the treatment of postmenopausal osteoporosis and also includes, I believe, use in men at increased fracture risk if they've been on hormone ablation therapy for prostate cancer. This is just one of a range of treatments that are available. But the key point about this drug is that it can be prescribed in primary care, although I'm not sure how much it actually is. But it's good to be aware as a GP that it should be part of a long-term personalised treatment plan, and most importantly, shouldn't be stopped without a plan in place for alternative therapy, because discontinuing this drug is associated with an increase in risk of multiple vertebral fractures. And there are recommendations in the guidelines about what alternatives can be used if a patient does stop taking it. So please do have a read of the guideline update as a concise summary of the NOG guidelines, and these can also be seen in full on the NOG website as well. Thank you very much for listening. The next episode is the last in our current season, and we'll finish with a seasonal focus, setting you up for summer with discussion of sunscreens and skin cancer, hay fever, and other problems that you might encounter. Thanks for listening.